So during the course of this lecture, we'll be dealing with how to evaluate a child with hematuria. And to start with the definition, hematuria obviously is the passage of blood in the urine. Now it can be macroscopic or gross hematuria, which is visible to the naked eye. You can see the red color in the urine or shades of red in the urine, so it can be macroscopic, or it can be microscopic, and this is defined as the presence of more than 5 red cells per high power field in a centrifuged sample. So macroscopic hematuria can be microscopic or macroscopic. So let's move on to detection of hematuria. Visual examination is extremely important. This is what brings a lot of patients to medical attention. You need to look at the urine, and by looking at the urine itself you can gain a lot of information. So it's very important to note your findings on visual examination. We'll deal with this the details a little later. You can use dipsticks, but remember, dipsticks will also show will show positivity for hematuria when there is hemoglobinuria, when there's myoglobinuria, and when there are significant amounts of ascorbic acid in the urine. So there can be false positive results with dipstick for hemoglobin in these for hematuria rather. With these entities, but it's a very easy method of detecting hematuria. And then obviously you have your microscopy, where you formally look at the urine under a microscope. And there are just a few images of hematuria, what hematuria looks like under the microscope. And we deal with we clinically talk about dysmorphic red cells. And dysmorphic red cells are the presence of dysmorphic red cells indicate that this hematuria is coming from the kidney. So it's a glomerular hematuria, and a glomerular hematuria is defined as hematuria occurring at a level higher than or proximal to the renal papillae, or higher than the renal papillae. So these red cells, the red cells that occur due to glomerular causes, because of their because they traverse the various membranes, the cells become dysmorphic. However, to definitely say that your dysmorphic red cells, there is a significant amount of dysmorphic red cells in the urine. You should have very high levels, as high as 70-80% of cells should be dysmorphic to be absolutely certain that this is a glomerular hematuria. And if your dysmorphic cell percentage is less than 20%, then that usually excludes a glomerular cause for hematuria. But in between 20 to 70, 80, it can indicate either. So it's just a helpful indicator, and it is definitely not a conclusive method of evaluating or conclusive method of differentiating between glomerular and extraglomerular hematuria. But it is helpful. This is how red cell casts appear in the urine, and this is the second picture shows granular casts. So these are all visible on urine microscopy, and the presence of red cell casts and granular casts, these do indicate a glomerular cause for the hematuria. So this is very important, and it is more conclusive than your dysmorphic red cells if present. What are the other causes of red cells in the urine? There is hemoglobinuria following hemolysis or intravascular, when there is intravascular hemolysis, and there is hemoglobin in the urine again would appear red or dark red. So this is important, and this is not really hematuria. The causes are different, and they can when there is significant rhabdomyolysis, you can have myoglobinuria again leading to red urine. Certain drugs like rifampicin are notorious to cause a color change in the urine, which can appear as hematuria. Foods like beetroot and some food coloring can make the urine red, and you can falsely think of hematuria. And there can be inborn errors of metabolism like porphyria and alkaptonuria that can lead to red colored urine. So these are all important to note. And we all know that urate crystals or urates in the newborn parents always come with a nappy showing pink color residue, and this is just urates. This is just urates in the urine. It's not hematuria, and you can reassure them because it's a benign entity. So let's deal with the etiology of hematuria. Firstly, glomerular hematuria. As I mentioned, it's glomerular hematuria is when the hematuria is due to a glomerular cause somewhere above the renal papillae. So acute glomerular nephritis, you all know acute glomerular nephritis or the nephritic syndrome due to inflammation of the glomeruli causes hematuria, but this will be accompanied by hypertension, edema and oliguria as well. There can be chronic glomerular nephritis. There can be certain inherited nephropathies like Alport syndrome that usually presents with hematuria and also is associated with deafness, and they progress to renal failure. And there is another entity called benign familial hematuria, which is, well, as the name suggests, it's a benign condition, but you need to observe these patients. They present classically with microscopic hematuria. The features of glomerular hematuria you need to keep these in mind. Now, this urine, I mentioned earlier that the color of the urine is extremely important. Glomerular hematuria causes brown or tea-colored urine. You do not get the bright red hematuria, and just by looking at the urine, you can suggest that this is probably glomerular in origin. Just through your through the naked eye examination of urine with the naked eye, you can suspect glomerular hematuria because this urine tends to be brown or tea-colored. So remember that the differentiation between glomerular and extraglomerular hematuria is extremely important because there's a completely different set of investigations that needs to be done for each of the two entities. If it's a glomerular cause, your investigations are completely different from when as to when it is an extraglomerular cause. So this is extremely important. And another feature of glomerular proteinuria is that there would be significant proteinuria as well. There would be significant proteinuria. There may be significant proteinuria. So if there is significant proteinuria, 2 plus or more proteinuria with the hematuria, this is not extraglomerular. This is glomerular. So if there is associated significant proteinuria, think of a glomerular cause. And as I mentioned, dysmorphic cells, dysmorphic urinary RBC, again is a feature of glomerular hematuria. But remember, to be absolutely sure that it is glomerular, or dysmorphic cell percentage should be higher than 80%. Then only can be absolutely certain that it is a glomerular cause. And if the dysmorphic cell percentage is less than 20%, then you can certainly say that it is an extraglomerular hematuria, not a glomerular hematuria. And these are I've just mentioned these as these features of glomerular hematuria in patients who are presenting with isolated hematuria. But obviously, if you have oliguria, if you have edema, and if you have hypertension accompanying the hematuria, oliguria, edema, hypertension accompanying the hematuria, it's obviously going to be a glomerular hematuria, and it is not an extraglomerular hematuria. So in these circumstances, you don't even have to do your dysmorphic cells, because you do not you need to differentiate between glomerular and extraglomerular. It is glomerular. If there is hypertension, it is glomerular. If there is significant proteinuria, it is glomerular. If there is oliguria and deranged renal functions, it is glomerular, not extraglomerular. Again, red cell CAS, as I mentioned previously as well, again that would indicate a glomerular hematuria. So red cell CAS, significant proteinuria, tea-colored or brown-colored urine, dysmorphic cells more than 80%, and also accompanying deranged renal functions, hypertension, oliguria. All these would indicate a glomerular etiology for hematuria. So continuing with the etiology of hematuria, let's discuss non-glomerular causes of hematuria, or extraglomerular hematuria, or lower tract hematuria. These are all used for the same entity. Now, urinary tract infections are the commonest cause of non-glomerular hematuria. These patients present with fever, dysuria, increased frequency, and so on. So you need to pick these in the history. There can be various urinary tract anomalies, like a patient with a hydronephrosis due to back pressure and rupture of blood vessels can cause hematuria. Renal and urinary tract tumors, which are not at all common in children, but it's a common cause of hematuria in adults. Bladder tumors and renal cell carcinoma, they can cause hematuria. The common entity in pediatric practice is a Wilms tumor, which is a tumor of the kidneys that occurs in very small children. These patients can present with a renal mass associated with hematuria. Urinary calculi will obviously cause painful hematuria, and with you can get your loin to groin radiation and features of ureteric colic. But hypercalciuria per se, without calculi, due to the crystals in the urine, can cause hematuria alone. So hypercalciuria per se can also cause hematuria. Trauma is another important cause of hematuria. So you always need to ascertain if there has been a traumatic episode in the region of the kidney or the GI tract. So these are all important to determine in your history. And certain vascular disorders or vascular abnormalities of the urinary tract, like hemangiomas in the bladder and in other areas, can cause hematuria. And hematological disorders, especially the bleeding disorders, again can present with hematuria. So all these things can present with extraglomerular or lower tract hematuria. So how do you evaluate patients presenting with hematuria? The history, examination, and investigations are extremely important, and I cannot stress the importance of history more, and even coming to a diagnosis, and you can even sometimes come to a diagnosis with the history alone. So you need to differentiate between painless and painful hematuria. Painful hematuria almost always means that it is an extraglomerular or lower tract cause. Stones, infection, tumor, they all will present with painful hematuria. Painless hematuria, on the other hand, is seen with glomerular or upper tract bleeds, but it can also occur with lower tract problems as well. Another important aspect that you need to determine in history is whether your hematuria is initial, diffuse, or terminal. Now, if the hematuria or the blood is seen only at the initial part of the urinary stream, this indicates a urethral problem, a problem with the urethra, or the bleeding point is in the urethra. So urethral causes of hematuria cause initial hematuria. Terminal hematuria indicates a bladder pathology. So you can have the initial part of the urine not having hematuria, and the last bit, or the terminal part of the urinary stream, has hematuria. Now these usually indicate a bladder pathology, either a stone or a cystitis or some other problem with the bladder. Diffuse hematuria, where your hematuria is the same from beginning to end, indicates an upper tract bleed, but it also can occur with lower tract hematuria when the urine when the hematuria has been in the bladder for a long time. You need to determine whether the hematuria is intermittent or persistent. Persistent hematuria can occur with certain causes of certain glomerular problems, like benign familial hematuria, which usually presents with microscopic hematuria. Intermittent proteinuria associated with respiratory infections would indicate an IgA nephropathy. Intermittent proteinuria can also be seen with urinary colics, with ureteric colics and calculi. So whether the hematuria is intermittent or persistent also needs to be defined. And I mentioned earlier the color of the urine, a very, very important aspect. Red colored urine indicates a lower tract bleed. Bright red urine, tea colored or brownish urine or maroon urine indicates an upper tract bleed, because these red cells have traversed the glomeruli and they have become dysmorphic, and then this leads to the color change in the urine. So what are you going to look for in your history? As I mentioned, fever, dysuria, frequency indicates a urinary tract infection. So you need to, the rest of your investigations would be pertaining to a urinary tract infection. If there's a history of skin sepsis or sore throat, think of post-streptococcal glomerulonephritis. If the hematuria is associated with an arthropathy or arthritis, and there is also accompanying rash, like a malar rash in lupus, or there can be alopecia, and oral ulcers, think of SLE. There can be a vasculitic rash in the extensor surfaces in the buttocks, then think of Henoch-Schönlein purpura. So these aspects in the history would suggest the diagnosis as well. So that's why the history is so important. Colicky, loin pain with loin to groin radiation and dysuria, think of urinary calculi. If there is bleeding in other places as well, you need to think of a bleeding disorder or thrombocytopenia. And if there is a history of previous heart disease, think of subacute bacterial endocarditis, or if there is a shunt, you need to think of a shunt nephritis. As I mentioned, if the patient is known to have a shunt, you need to think of a shunt nephritis. If there is associated deafness, and there's a family history of deafness and renal disease, this would indicate Alport syndrome, which is a familial nephropathy. So all these aspects need to be looked for in your history. Family history. When you take your family history, you need to establish whether there has been chronic kidney disease. This can happen with IgA nephropathy, which can be familial, Alport syndrome, and various other entities which can be familial. Look for a family history of hematuria as well. Again, Alport syndrome or benign familial hematuria, both can have a family history of hematuria, but for that matter, family history of hematuria might indicate calculus disease or stone disease as well, which again tends to run in the families. Family history of deafness is extremely important because this would indicate Alport syndrome. Family history of hypertension again might indicate renal disease and conditions like Alport syndrome and IgA nephropathy. So you need to look into that, and there can be a family history of nephrolithiasis or urolithiasis, which would indicate stone disease. There can be a history of hemoglobinopathies when these patients can present with sickle cell disease. These patients can present with hematuria as well. And a family history of coagulation disorders would indicate the obvious cause for. Let's move on to examination. Now, on examination, if the child is edematous, or there is pallor, or the patient has rashes or arthropathy, all these would indicate that there is significant renal involvement and that the hematuria is due to a glomerular problem or a glomerular pathology. If there is bleeding tendency, the child has evidence of bleeding manifestations elsewhere, the likelihood is that the hematuria is also due to a bleeding tendency. Fever would indicate usually the presence of urinary tract infection, but some of the connective tissue disorders like lupus can present with fever. There's hypertension and heart failure. You need to think about acute glomerular nephritis and again a glomerular cause for the pathology. And if there are palatable renal masses like hydronephrosis, then you need to consider whether this is a PUG obstruction with a hydronephrosis or whether it is a Wilms tumor that has presented with a palatable renal mass. And renal angle tenderness would indicate the presence of pyelonephritis, and that being the cause of the hematuria. So remember, edema would indicate a nephritis, would usually indicate a nephritis. Pallor would indicate significant renal involvement. Rashes and arthropathy, a connective tissue disorder like lupus or henoch-Schwann-Like purpura. Fever, renal angle tenderness, urinary tract infection, palatable masses in hydronephrosis due to PUG obstruction or a Wilms tumor, and hypertension and heart failure with acute glomerular nephritis. So these are what you look for when you're examining a patient who presents with hematuria. What are the investigations you would do? So obviously you're going to do a UFR to confirm the presence of hematuria, because we did discuss the mimickers of hematuria. So to confirm hematuria, you're going to do urine UFR, and the UFR is extremely important when investigating for hematuria, because it does give a lot of clues as to whether this is an upper tract or a lower tract bleed. So if it is an upper tract bleed, the hematuria will be associated with red cell casts or granular casts. So that would indicate an upper tract bleed. If there's proteinuria more than 2+, that again would indicate that this is an upper tract or a glomerular cause of hematuria. The presence of a significant amount of pus cells would indicate pyelonephritis. Again, that is helpful. And if your history and examination have not been able to differentiate whether this is an upper tract or a lower tract bleed, or if there is doubt, then you do your dysmorphic red cells. And I've mentioned repeatedly that a dysmorphic red cell percentage of more than 70 to 80% would definitely indicate a glomerular pathology. If it is less than 20%, a glomerular pathology would be unlikely. So if a glomerular cause is likely, then these are the investigations you would do. You do a full blood count to look for other cellular line involvement like thrombocytopenia and leukopenia in lupus, the serum creatinine and serum electrolytes as renal function tests, the albumin and cholesterol to see whether there is a nephrotic mix picture, or to see whether there is a nephrotic mix picture, and also it is helpful in a patient with nephritis as well. ASOT and complement C3C4. ASOT for to define the etiology of the acute glomerulonephritis as post-streptococcal. Complement C3 and C4 will be low in a post-streptococcal. C3 and C4 both may be low in mesangiocapillary and glomerulonephritis and lupus. So these are also important if the hematuria suggests a glomerular. Suggests that it is due to glomerular cause. If you're suspecting lupus, you need to do your ANA and double-stranded DNA. If you're suspecting IgA nephropathy, you need to do the serum IgA levels, which may be deranged in a minor percentage of patients. And if the patient presents with a rapidly progressive nephritis associated with hematuria, you need to do your ANCAs and your anti-glomerular basement membrane antibodies. So you'd see that if the history and examination and basic investigations point to a glomerular cause, these are the things you're going to look for. You're going to look for the etiology for the nephritis, or for basically the etiology for the nephritis. And ultimately, to get a definitive diagnosis, you might need a renal biopsy, and this would not be indicated in conditions like post-streptococcal nephritis, where everything else which is self-limiting, so it's not necessary. But in most of the other conditions, you would definitely have to do a renal biopsy to come to a definitive diagnosis. So what are the investigations you do if it is likely to be a non-glomerular cause or a lower tract cause for the hematuria? So you need to do a urine culture, because this is the commonest cause of lower tract bleeding is a urinary tract infection like cystitis. An ultrasound scan will be helpful to look for stones, look for calculi, look for other structural abnormalities, look for bladder wall thickening that can occur with chronic cystitis. So an ultrasound scan will be helpful here. A urine calcium creatinine ratio, if you're suspecting hypercalciuria or urolethalgia.
diastasis. A clotting profile if a bleeding diastasis is likely, and sickle cell screening because sickle cell anemia can present with hematuria. And you might need to do a urological referral for a cystoscopy if everything points to a low tract bleed, but you cannot identify the exact focus for infection. So you see, once you've established that this is a lower tract bleed, the line of investigations that you would pursue would be completely different as to when it is an upper tract bleed. So this algorithm just basically summarizes what we've just discussed. So if you have gross hematuria and the likelihood, and you see bright red colored urine or pink colored urine with no dysmorphic cells, no cast, minimal proteinuria, that is a lower tract bleed. Look for dysuria, abdominal pain to exclude an infection, and look for urological causes of hematuria. So you do a urine culture, ultrasound scan, calcium creatinine ratio, and sickle cell status, and you might need a urological consultation for cystoscopy. If the hematuria is Coca-Cola colored with significant proteinuria, dysmorphic cells, and cellular casts, that would indicate an upper tract or glomerular bleed, and the hematuria would usually be painless. So you need to consider renal disease and look for a nephrological cause for the hematuria and investigate as we have just discussed. So what if your patient has only microscopic hematuria and there is no proteinuria, no hypertension, there's no family history of chronic kidney disease or deafness, and there's normal physical examination, and your urine culture is negative excluding an infection? So these patients, this hematuria, so isolated microscopic hematuria, is not an indication to do a biopsy, even if you do not have a diagnosis, because isolated microscopic hematuria is not harmful to the kidneys. But you do need to follow these patients up regularly, because the isolated microscopic hematuria can change and these patients can develop proteinuria, hypertension, and at that point, if they do develop proteinuria or hypertension or derangement in renal functions, at that time you need to do a biopsy and look for the definitive cause. So if everything is normal, you check the parents and siblings for the presence of hematuria, and if there is a positive family history and the patient has only microscopic hematuria, you can consider benign familial hematuria, but you need to follow these patients up because you're not doing a biopsy, you don't have a definitive diagnosis, it's just a suspicion. You need to follow them up maybe every 3 to 6 months with a blood pressure and a urine analysis and maybe an annual renal function, but you need to follow them up because the picture can change. If there is no family history of hematuria, you do a calcium creatinine ratio and a renal ultrasound scan. So if the calcium creatinine ratio is elevated, you need to evaluate for hypercalciuria. In the ultrasound scan, if it is abnormal and shows either a structural abnormality or urological cause for hematuria, you need to investigate on those lines. If the patient, on the other hand, has microscopic hematuria associated with proteinuria, hypertension, abnormal renal function, a family history of renal disease like IgA nephropathy or chronic kidney disease or Alport syndrome, or if there is a family history of deafness suggestive of Alport syndrome, consider glomerulonephritis or tubulointerstitial nephritis, or consider Alport syndrome. So you need to do a detailed hearing test and investigate for the possible causes of glomerulonephritis, including a renal biopsy. So these are basically what you're going to do if the patient has microscopic or macroscopic hematuria after you do the basic, take the history, examination, and investigations. So follow-up would definitely depend on the cause. Asymptomatic microscopic hematuria hematuria, as I mentioned, is likely to be benign. You can do an annual review for the development of proteinuria. May have to do it more frequently initially till you get to grips as to how things are changing, and you need to review with looking for proteinuria, hypertension, and derangement in renal functions. And if any of these, that is proteinuria, hypertension, or derangement of renal function, does develop, you need to do a renal biopsy. Thank you very much. I will end this lecture here.